Right. Good afternoon or morning, depending on time zone, and welcome to today's webinar titled Appropriate Use Criteria Part 2. We appreciate you time out of your busy schedules to join us for this 60-minute web session. Before we start, let's cover a few housekeeping items. All attendees have been put on mute in order to eliminate background noise. We encourage you to interact with the speaker presentation by typing your questions and comments into the Q&A panel. Your questions will be answered following the presentation as time permits. May not get to all of your questions live, but we will be providing you with an FAQ document with questions and answers received throughout today's session, as well as the PowerPoint presented, a link to the live recording, and a certificate to obtain your CEU within 5 business days. Let me reiterate, within 5 business days, you will receive an email that will have an FAQ document with today's questions and answers, the PowerPoint presented today, a link to the live recording, and a certificate to a CEU. Today's presenter is Ardith Campbell, Manager of Product Content here at Vitalware. Ardith, the show is yours. You now have the floor.
All right. Well, thank you very much, Julie. And I do have some PDF documents that I will be sharing. So if those are not displaying appropriately, if you could hop in and tell me to adjust my share settings, I'd appreciate it. And welcome to our appropriate use criteria. I have used the who, what, where, when, why, and how for our part 2 session, as well as just to kind of follow up with as our part 1 session. Just the basic disclaimer that you'll see all over the place, that it is current as much as it can be current. I will let you know that I do have some G codes referenced later in the presentation where the codes have been published in a transmittal, but the files with the descriptions have not been published yet. So I'm hoping to have those within our 5 business day windows so I can send that information to you. But I did check the CMS site just shortly before signing in to do the presentation, and of course they were not published yet. So really the basic objectives that we want to get to today is what has changed since our presentation that we did in October. And you'll see that I've used a lot of the same slides, and I've got a little icon on them that says same, because I hate having to try to flip through 2 different presentations, finding the information I need. But when we have updates, we will go ahead and have the updates. There are updates to the claims processing procedures. And then for our last session, we did not get a chance to go in and really investigate some of that appropriate use rationale. So I've got a couple of the policies or the appropriate use criteria documents that I'll go through and share with you. They're really fascinating. All right, so when are the important dates? What updates to procedure codes? Anybody new to the program? Covering where does reporting take place? How are we going to submit claims? And the why is kind of digging into some of that clinical decision making, which is going to be looking at the appropriate use criteria documents. All right, so the overview is there are some provider-led entities that develop the appropriate use criteria, like the American College of Radiology. So it will be folks that you know, and then they have developed this criteria. So the clinical decision support mechanisms are going to take that criteria to create an electronic portal to determine if the physician order or the providers of record orders is going to adhere to the appropriate use criteria. And the ordering provider is supposed to consult that clinical decision support mechanism for certain specific clinical indications, and then those furnishing providers are going to have to report that information on the claim. So the ordering provider does not have to report anything on the claim, but the furnishing provider does. And so that is going to be for both the professional and technical components. The modifier goes on the advanced diagnostic imaging test. And there are specific HCPCS codes to use for the specific clinical decision support mechanisms that's used by the ordering provider. So one of the challenges is going to be the communication from the ordering provider onto whether or not they've checked for the CDSM and whether their order applies or not, adheres to the criteria or not. So, so when is all this supposed to take place? What are those important dates? Well, the mandatory reporting was starting January 1st of 2020, but CMS has decided that that's really going to be an outreach and education through this year. So there will not be any claims denials for non-reporting during the year, but it is supposed to be fully implemented January 1st of 2021. So after that time, we can probably expect to see claims denials. So there really are no changes to any of the dates. So other dates that we'll need to watch, quarterly code updates and the semi-annual and annual additions to the provider-led entities and those clinical support decision support mechanisms. Because the clinical decision support mechanisms have G codes attached to them. So what updates have there been to the procedure codes? So we have just come through the annual update process. It has not been as easy as prior years, I believe, but the clinical diagnostic areas, there's no changes to those. So your coronary artery disease, if it's suspected or diagnosed, you know, traumatic or non-traumatic headache, hip pain, low back pain, etc. So if the patient's diagnosis does not fall within these areas, you do not have to check their clinical decision support mechanism. Now you still can, but it'll just be able to tell you that, you know, nope, you don't need one for this. So depending on how you want to see those or have your processes in place will determine that. So the advanced diagnostic service areas are the same. So it's not going to be your, you know, your plain film chest x-rays. Those are not included. So your CTs, your PET scans, nuke med, the advanced imaging. Now there are changes to the codes because there have been some changes to the MRI codes. So they have deleted like the 770, 58, and 59, added the 770, 48, and 49. I have listed those for you on the slides. So the codes in October are going to be like that first bullet point, and then where there are any additions, I've highlighted those in red, or changes, I should say. No changes to any CT codes. Nuclear medicine did have quite a few changes, so they're actually on a couple of different slides. So this is showing you the deletions, and then more deletions, and then these codes are the additions. So the 76390 for your SPECT has been deleted, and then the C codes remained the same. All right, so who was affected? Again, it's going to be, you know, all physicians and practitioners who order advanced diagnostic imaging services, and so also it's going to affect the providers and facilities who furnish those services. So if you are in, you know, if you have your own machines there in your physician's office, or you're in the hospital outpatient department, and that does include your emergency department, an ASC, or you know, an independent testing facility. So if it's paid under the Prospective Payment System, your OPPS, your Physician Fee Schedule, or your ASC, those will have to be reported, but a critical access hospital is not one of the payment systems that was tagged as having to do this. So you're also your federally qualified healthcare centers and those. So just wanted to touch base on those. So who is writing the appropriate use? Well, they have to be a national professional medical specialty society. So this is really no change here. And they are posted on the CMS website. And I've got the link for that in the references. And so here are some of those, the ones that are all the same. Some very high profile folks that are writing these. So it's people that you probably know. All right. Now, who is the clinical decision support? And so your provider-led entities, so those folks that we just went through are creating those clinical benchmarks, and then they are supposed to be added to a tool. So it's supposed to make technology work for you. But you know, sometimes technology does what we tell it to, not what we want it to. So we need to make sure that that system is working appropriately for us. And so that clinical decision support mechanism is providing that technology for us. And that can be something that is integrated into your electronic health record, or it can be something that is standalone. So here we've got the folks that were the CDSMs that stayed the same. So there are several, but we do have some updates. The speed of care CDSM is new, but the other ones, such as your Cerner CDS mechanism and Evidence and Flying Aces, those guys have been removed. So we expect that when the quarterly updates come out, we'll also have some changes to some of those G codes other than the new ones that they've published. All right, so what are the exceptions? And that is going to remain the same. You know, if you have something where it's acute, where somebody could really be hurt by not getting that immediate attention, or a pregnant lady that's having contractions. And so, of course, does not need to be for inpatients. And then sometimes if you have, you know, the internet is out, or you're having vendor issues with your CDSM, and then what they call the extreme and uncontrollable circumstances. So think of, you know, when a hurricane or tornado has come through and wiped things out, and so you're kind of going on the fly there. All right, the logistics are pretty much the same. So if we have a patient coming in for low back pain, of course, the treatment's going to depend upon that patient's condition. Are you going to be referring that patient for advanced diagnostic imaging? Yes, then you can check the CDSM for your appropriate use. That can be delegated to another staff member, but that person needs to understand whether they're doing this correctly or not. And then you're also not required to follow the recommendation. Right now, they're just trying to gather the information. And then you'll want to make sure for the ordering provider that that information is getting sent over to the furnishing provider, because the furnishing provider has to submit that information on the claim. All right, so your the CDSM, that it can be completed by your competent clinical staff. You know, for example, you know, which cervical area are you wanting the checked? You know, do they know the difference between ileum with ILI and ileum ILE? So it's just, you know, make sure that that person understands some of those differences. So that person can go ahead, get access to the decision support tool, enter the information, get results, and then take those to the provider and possibly even the patient. So if you have your nurse or medical assistant doing that. The same, so the applicable setting is where that imaging service is furnished, whether it's your outpatient hospital, ASC, or your independent testing. So the radiologist who is performing this, as well as the facility claim, needs to have the appropriate use information on their claim when they submit it. And of course, the exceptions that we kind of went over a little bit earlier. All right, so how to report, and this is where we're going to have some sameness and some differences. So the furnishing provider has to have 3 data elements on the claim. So you have your CPT or your HCPCS code for the service that was furnished, and then you have modifiers that are attached to that imaging service, and then G codes to identify the clinical decision support mechanism that is consulted. And it is okay to report multiple. And there's also a modifier for unknown. So that's kind of helpful. It gets the providers, if you don't know if that was done, gets you off the hook, but it's not going to be very helpful for gathering information for CMS anyway. So the modifiers are the same so far. I haven't seen any changes to those. There is, so when you have the modifiers, the ME, MF, or MG, which is the item has been, the appropriate use criteria has been consulted. Then the G codes, there are some changes. So the G1001 is going to be expired. So after April 1st, you will not be using it because this clinical, the applied pathways is dropped off. And so we're all the same. All right, but here's where we have the new ones. And I'm assuming that since the last code was the G1011, that the G1012 through the 19 will be the new clinical decision support mechanisms that are coming out. So when I checked on February 14th, there were no changes. When I checked today, there were no changes to the HCPCS code files. So I have no descriptions for you. If they are published within our 5 business days, I will be sure to send those out. Also, if you have, you know, our CDM tool, you can run a report and help find some of those as well. So kind of helpful, not very helpful. So just something to keep your eye out because, you know, CMS doesn't keep you guessing enough as it is. All right, so the furnishing provider, you have your procedure code and your diagnosis code for the test performed, the ME, the order for this service adheres to the appropriate use criteria. The G1003, because I'm pretending that we checked the Medicalis decision support mechanism. I'll need to have the NPI's ordering, the ordering and provider's NPI for each line of service. Now the claim information holdup here was that for facility claims, you had no way to report a line item NPI for each patient. So that has been updated. Woohoo! So according to a special edition article 20002, CMS is now saying use the K3 segment and to use the ordering NPI within there. So that first example, is telling us that this is for the K3 star. The appropriate use criteria is the what we're doing, and so the then it's for LX1 for line item 1. The ordering provider's NPI is, and then they've got ones, and so in that second example where it has for 5 ordering physicians, it's the AUC LX1, it means line item 1. DK indicates the ordering provider's NPI is the next part to come. And then we have the LX11, so that would be for line item 11. The DK is the ordering NPI for the next provider. And so it just kind of all nice and streams together. The lucky for us though, that special edition article does, oh, well, that was not where I wanted to go. Sorry about that. Let me see if I can open this. Nope. Okay, so we are going to go to Plan B. Let me bring this over to the larger screen here so we can see it. And I believe I'm going to have to check my share. All right, because I am assuming that you're not able to see my screen yet, so let me get to the right button here and do a new share of this one. Okay, so that should be sharing for you. All right, so here we've got an example of an emergency room claim. It's so nice to see it in the format that my brain can actually understand. And so yeah, I've got my descriptions listed with the revenue codes, the descriptions, and then here within the field locator 44, this is going to show me that I've got the 74261, the MA, because it's not required to be reported for that condition. And then down on the line item for the 612, let me get my little annotate here. Better change it to a different color so we can see it. So here we've got the 612 for the MRI, and it says MRI of the spine. So we've got the 742148 for that test. The ME modifier saying the CDSM was consulted and it does adhere. And then just below that, I have got my G10XX code that is telling CMS, okay, this is the supporting mechanism that was consulted. Now for the claim scrubbers that are going to require you to have a dollar amount or a value amount in the total charges column, CMS says a minimal charge, so that's anything that's $1 or under. So if you wanted to have a penny, 99 cents, whatever, that is going to be, that part is not going to be consulted as part of when they're doing the claim processing. All right, now let me do, oh, that's page down. All right. All right, and so for this one, this one has an easier one. The MB modifier the ordering professional had insufficient internet. And that can happen for a number of reasons, especially if you're having a, sometimes if it snows a lot, depending on your area. You know, here's another example using the modifier where there were EHR or CDSM vendor issues. So the supplemental or the special edition article does give you a lot of information for examples. Now, I did not include a physician 1500 on here because, you know, it'll look a little bit different in the format, but you are still going to use the same procedure codes, the same modifiers, except on your 1500 over on the left-hand side, of course, you've got your spot for your ordering provider's NPI. So that is a little bit easier for you. And so they do have examples here for you to take a look at. And so it is pretty helpful. It just doesn't let you see the K3 spot where you would have your ordering provider's identifier, but the line item like this one, it would be the LX1 for line item 1. All right, let me get back through my going into the why. So this kind of gets into the why is this occurring? And CMS for quite some time has wanted to make sure that you're doing the right services in the right setting, in the right intensity, and that it's not for convenience or cosmetic. And I kind of use the Pursuit of Happiness movie because as soon as I recognized what Will Smith was carrying around, I knew my compliance brain kind of went back to the trauma of back when they were selling those portable kind of bone density measuring scans, where, you know, suddenly the physician has this new fancy tool, and so everybody was getting bone scans. Unfortunately, the CPT code that was being reported was for the bone density scan, where you get laid out on the huge table for a complete bone scan. So anyway, so it did come with lots of headaches, and this worked in practice. I swear it really did. All right. So we will go to the chronic chest, and please, Julie, let me know if we're not able to see this. I should still be sharing.
Yep, I can see it.
Okay, great. Just wanted to make sure. All right, so here is some information from the American College of Radiology for the headache. And so this is, and then there are different variations to kind of give you a clinical setting. So this is where the patient comes in and they've got a sudden severe headache, or it's their worst headache of their life. And so this says, okay, if you have a CT of the head without contrast, that's usually appropriate. And then the little icons on the left-hand side, they do kind of say how much radiation exposure to the patient is involved. All right, so now your second variation is when the patient comes in, this new headache, sudden onset, but they have optic disc edema, excuse me. So usually your head, your MRI head with and without contrast is usually appropriate. Same with your CT. Now, if you're looking for your CT venography, those may be appropriate. So it is going to take into consideration what else is going on with your patient. And so in these, if it's usually not appropriate, it will be highlighted in red. So this goes in and, okay, so now you've got your variation 3, you've got a new or progressively worsening headache, and some red flags. Subacute head trauma, related activity, neurological deficit, possibly known or suspected cancer, somebody who might be currently pregnant. And so what is appropriate, what might not be appropriate. And so I'm going to go ahead, I apologize for screening, and because down within the documentation, they'll let you know who specifically worked on this criteria, and so what's the rationale. So what are some of the most common clinical scenarios, and what is the most appropriate imaging for that assessment? So, as time goes on and medical practice is changing, we can, expect some changes in this as well. And the nice thing about this is that within these documents, they will hyperlink into additional documents created by the American College of Radiology. And so, it says they've got your primary and secondary forms, your primary headaches or your migraines, tension types, and then there are others that are just, who knows where they came from. And so then it even goes into, okay, so what are the different variants? And they go into discussions on those. So your sudden severe headache or the worst headache of my life, they're taking a look at, possible ruptured aneurysm and other acute intracranial hemorrhaging. And so that's what they're wanting to take a look at. But it can also overlap with what they call their thunderclap primary headache, or some of your reversible cerebral vasoconstrictions. And so then the CT of the head versus a CTA of the head, for the CT, that is going to be your most appropriate initial imaging test. But your CTA, your angiography is really not indicated in the initial stage. But if but there are some variations. Let's see. Let me get my little thingy-bopper here. Let's see. First degree family members with aneurysmal sudden acute headaches. And so it does go into when it might be appropriate, what's not going to be appropriate. The MRI and the MRA really are not used in this one. So with the optical disc edema, their information says that it's, your increased intracranial pressure. And so some of those differential diagnoses are going to mean that, okay, you may need to have additional impetus put on to getting that test done. And so then they also say, with patients with that idiopathic intracranial hypertension are usually overweight females of childbearing age. And so they do, but state, imaging with your MRI or your MRV or your venography is included in that diagnostic criteria for that condition because of the possibility of venous thrombosis or your venous sinus stenosis. So the documents provide a lot of information as to where or why. And there was some more information. I wanted to go down to, I believe it was page 12. And so they also have supporting documents. So you can link into all kinds of more information. So if you love studying, a lot of information is in there. So again, for pregnant patients, they provide some information. And then down at the bottom here, they kind of give the numbers for the appropriateness rating. So your 7, 8, or 9 is going to be usually appropriate. Your 1, 2, or 3 is usually not indicated in the clinical scenarios that they've specified, or that the risk-benefit ratio is unfavorable. And so then down at the bottom here is when they give you that how much radiation is in here. And then below that, they list out all of the information. So it's really very intense. And this is just a little bit of it. If you go to the to the ACR website, which I have linked for you in the references, there are documents that are 100 pages that provide more detail behind what's just given here in this kind of synopsis document that they have published on their website. All right, so we did mention low back pain. So let me increase this one here. So this is someone that maybe has acute, subacute, or chronic uncomplicated low back pain or radiculopathy, no red flags, and no prior management. So this one is got, any of your advanced diagnostic imaging is a 1 or a 2, meaning it's usually not appropriate. But it does state that if there is a concern for the spondylosis in a young patient, SPECT CT is the gold standard. And it could be that, you're the first one they see to get that started. So, here we've got as the second variant is acute, subacute, or chronic uncomplicated back pain or radiculopathy. And then they also have 1 or more of the following. You had a low velocity trauma, patient has osteoporosis, could be an elderly individual, or they could be on the stone cold Steve Austin end of things. And I don't know if he does chronic steroid use, but there are folks that do those. So, but my grandson loves WWE wrestling, so that just came to mind. So the usually appropriate is going to be, just your lumbar x-rays, your x-ray of the lumbar spine. You may have, that does not need to go through the appropriate use, because if it's just, like, well, plain film, which isn't really film anymore these days. But when you get into the CT or the MRI of the spine without contrast, those are kind of more appropriate. So that's, if you're thinking there might be a vertebral fracture, or you might want to go ahead and go with the CT if you think it might be something that is a ligament injury, that might be more in your MRI area. But things like your myelographies and discographies are not normally clinically indicated. Of course, if the patient has other concerns that you're taking a look at, then of course, do what's right for your patient. And so here's one where the variant 3, where there is a suspicion of cancer or infection or immunosuppression, then of course your 7 and 8s are your MRIs. You know, they just kind of go down the line of what's more appropriate. You know, your 5s and 6, your CTs could be, you know, at that point, if you're suspecting cancer or infection, or someone who has an immunosuppressed disorder, geez, come on, tongue, let's work. That is kind of more along the lines of, yeah, maybe not. But if you feel that that's the best for your patient, you know, be sure that you do that. But on that third column, they are telling you that, you know, like your MRI of your lumbar spine without and with IV contrast, that's useful for patients with neoplasia and have a suspected epidural or intraspinal disease. So they do provide kind of a quick feature there. So hopefully this is all loaded into your clinical decision support mechanism. And so this is really really good information that you can take a look at, and you can see, you know, the ACR has said they've spent over 20 years developing all of this information, and so it's great just to be able to see it, you know, nice and in one spot, so you don't have to go looking all over Timbuktu for it. You know, so here we've got variant 5, which is they've got low back pain or radiculopathy and new or progressing symptoms, and they have a history of prior lumbar surgery. So they're saying, you know, the 8, so here on top is more is the highest one that they would go for. And the reason why is because this can differentiate if there's an issue between something wrong with a disc or if it's scar tissue. And so then if you go down to your x-ray of your lumbar spine, you know, maybe you don't need to do the CT or MRI yet. This one points out that, you know, your flexion and extension views can be useful. So it kind of provides some of that additional information. So, you know, here they give you a summary of the literature review, and so it does state, you know, that now it's, you know, uncomplicated low back pain or radiculopathy really is a self-limited condition that does not necessarily need any additional imaging. But where you have a patient that's had, you know, up to 6 weeks of some medical management or physical therapy that had little or no improvement, then you might want to take a look to see if there are any other red flags going around. So here they've listed out some of the red flags. You know, of course, if they have a history of cancer, I don't know if this person I would necessarily wait on, you know, but they've had a history of significant trauma, you know, the saddle anesthesia, global or progressive motor weakness in the lower limbs. So just, of course, it is going to be based on, you know, how is your patient doing? And do we need to see if there's anything else that we need to do? And then they'll also point out, you know, for those patients that have, you know, that are without a neurological compromise, but who have minor risk factors for cancer, you know, or your inflammatory back disease or other items, that, you know, the imaging should be considered after a trial of therapy. You know, like physical therapy. So they do give you some pointers there. I think it's awesome. Now, in the CPT assistant that we just received not too long ago, they had an example of a patient who came in that had the patient had slipped out on the ice and now had edema and swelling of the knee, had been and has gotten worse over the past 3 days. So they had a twist or a fall. And so then what is going to be appropriate to order for the patient in that instance? Well, you might want to get a radiograph of the knee, but if they're having some other issues, that will kind of determine what else might I need to do for my patient. So if you're suspecting that there might be some type of fracture or internal derangement, or ligament tear, then you're going to fall within some of these other variants. And let's see, the chest pain one that I found, I wanted to go ahead and give this one a little to go into the chest pain, because this is probably one that may come up quite a bit. But they do list out, if they have chronic chest pain, high probability of coronary artery disease, well, where do you start? And so the ones at the bottom are going to be not appropriate, where the 4, 5s and the 4, 5s and 6 are kind of mid-range appropriate, where they're saying the ones up here at the top are going to be the most appropriate. So, so your chest x-ray will show you some information, but you might want to take a look at, depending on what else is going along with the patient, you might need an MRI of the heart to get information on the function with your vasodilator stress. So you have your stress test or an arteriography. So whatever, this isn't to take place of what is going on with the patient, but just kind of gives you an idea of, okay, this is going to be most helpful, this is not going to be most helpful. And, there are some patients that may have nothing going on and have heard about, this horrible disease, and so now they want, every test run under the sun. And sometimes you can, use these types of articles to say, hey, this really isn't the best for you, because look at all of the radiology you have to, the exposure you would have. Let's maybe start small. And you never know, it could happen. And so this information is just really very informative. And so again, this is a lot of information, trying to kind of get it down into something that's within, a peaceable chunk that you can actually digest it and take a look at it and see what's going on, and to maybe come up with some patient, if you need some patient information to provide on why the test is good or not so good. It gives the rationale behind that, and kind of gives you a head start on that. So the clinical decision support mechanisms are supposed to take the information from the provider-led entities, such as the American College of Radiology, and incorporate that into that support mechanism, so that when you're in typing away as, the patient's diagnoses, we want to do this, and give you the information of whether it meets criteria or not, so that you have that information to be able to send to CMS, so that all of that can, of course, be tracked. And the reason for all of this tracking is that CMS is going to find out, who are the outlier providers that might be over prescribing these tests, and it's possible that if somebody is an outlier, either over or under, that they would have to work on a prior authorization program before having a test approved to be run. Now, of course, if the patient is, in that emergent condition where, the loss of life or limb, or possibly the loss of a baby, a newborn, those are exempt. So, so just remember, there's some different scenarios to go along with a lot of this. And let's see. So we're getting down near to the end. So how did we do? So we discussed what's changed since our last presentation. We've had some clinical support mechanism folks hop on and hop off. There have been the updates to the claims processing procedures, so that you can use that K3 segment for the electronic billing. And then we took a look at some of that appropriate use rationale. And then we've got a link to the appropriate use criteria site, the College of Radiology site for their decision support, and then also that the transmittal, the 20002 that we took a look at, they did have an update to that fairly recently. I believe it was on the 17th of February, but they didn't change anything with any of the codes. It was more along the lines of adding some information in there for, I think a couple of the G codes. It was, for correct reporting, contact the clinical decision support mechanism. So it wasn't anything that was too noteworthy. But other than that, Julie, if you want to go ahead and start reading off the questions, if we have any.
Absolutely, we do. And I do want to mention again that we have had several questions come through, but just sake of time and to be respectful of everyone's time, we only have a couple more minutes left in the webinar. So if we don't get to your question, rest assured that we will include it in the FAQ document with an answer and send it out to everyone in that email within the next 5 business days. So here's the first question, Ardith. Is the minimal charge on the G code just for the facility or the professional claim as well? I'm sorry, there's just one more piece to it. It says, I do professional radiology billing and we set G code as a $0 charge.
Okay, it would be for professional or facility. It's whatever it takes to get that line item through your claims processing system so that it gets out and sent over to CMS so they have the information. So there are some systems that don't accept 00. And so you have to have at least a penny in there, but CMS says as long as it's under $1 and a penny, that's fine with them. Way back in the day when they started doing the physician voluntary reporting program, which is now morphed into the merit-based incentive payment system, when it was time to start reporting, the physicians added, it was supposed to be 00, so they had no the no dollar amount on there, and the clearinghouses were stripping those line items, and so the information did not get submitted. So it's just in a, in an attempt to make sure that that information is recognized by the clearinghouse as a valid line item of service so that it can get out and get reported. But as long as it's, under $1, CMS says that's great. And, you're going to be asked to write off any dollar amounts associated anyway. So if your clearinghouse will accept the 00, that works. And it could be that that was so long ago that, they've updated their software systems to be able to accept the 00.
Okay, great. And I do want to ask you a quick question before on to the next one. Will these PDFs, so the clinical documentation files for headache, LBP, chronic chest pain, knee, so forth and so on, are we include those?
Yes.
Okay.
Yeah, and unfortunately, I practiced this, I swear, yesterday to be able to get those to open, but I will make sure that you've got a copy of those so that they can go along with the presentation out to everybody.
Okay, perfect. Okay, I'm going to get to our last question, and then we're going to have to close again for the sake of time. Did you touch on any of the billing and reporting of the consultations? It says, I'm curious how many facilities are currently reporting on their claims that a consultation was or was not performed, and why? Is anyone else experiencing delays with the billing packet from their EMR?
I have not heard that, but each EMR is going to be different, and I would expect, because Cerner dropped off, that it is occurring for other folks. So that is also something that CMS took into consideration, because that's one of their modifiers, is there was an issue with the electronic record or the CDSM vendor. And so you can go ahead and use those. I've not personally heard anything, but if I do hear something, I will send that out in the FAQ document.
Okay. All right. Well, again, those are all of the live questions I'm going to take today due to time constraints. That was fabulous. I'm always in awe, Ardith, with the knowledge that you store in that brain of yours, and you're able to go through and say those words. I know you said earlier that your tongue was tied, but it sounded great to me. So thank you so much. And again, we're going to be sending an email with the FAQ document, a link to the PowerPoint, a link to the live recording, and a certificate that you can use to obtain your CEU within 5 business days. If you'd like more information on what you saw today and you're a current VitalWare client, reach out directly to your account manager and ask them to get in touch with Ardith. Or you can reach out directly to me at events@vitalware.com. And make sure you stay up to date with VitalWare's future webinars by following us on LinkedIn and checking out all of our upcoming webinars on our website under the reference tab. So again, with that said, we thank you for joining us today. We hope you found it very informative. And Ardith, thank you very, very much. Have a great day, everyone.
All right. Thank you.